So the goal of today's talk is really just to kind of talk a little bit more about chronic pain and some of the options that are available. Kind of specifically, the way that I like to think about pain and all of the options that we have is really a big 5-tiered system. The first part of the journey is figuring out what's going on for the patients, really understanding the diagnosis, exactly why you're having the pain that you're having, and what's the main source of that pain. And then from there, we can make the decision to either do something or for a patient to live with it, because some people, do choose that, I understand what's going on, but I'm going to just choose to live with this pain. As we step up in terms of invasivity of some of the things that we're able to offer, the next level after diagnosis is usually what I like to call physical modalities or external options. And so that includes things such as physical therapy, topical ointments, bracing, all of the non-invasive ways to be able to help. As we continue up the ladder, there are medications, both so you generally starting with over-the-counter medications and slowly working up some of the prescription options. And then we move on to the interventional options. And so most commonly people hear about things like steroid injections, which are very common and do help quite a lot of patients. But then we're going to kind of talk about some of the procedures today specifically that fit in between that point and the surgical option, which is the fifth option. And from our perspective, obviously surgery is a great tool, but for a lot of patients, if we can control your pain without having to go to the full surgical route, we feel that that's going to be a great option for you. Next slide, please. So as we're starting to understand what's going on with your pain and trying to diagnose the pain, one of the first things that we have to understand is whether or not it's a mechanical pain or a neuropathic pain. And really, the differentiation that I like to describe for patients is a mechanical pain means that every time that you go into one position, or whether you're putting pressure on a certain location, you're going to cause pain because there is something that is physically happening. There's an anatomic structure or change that's happening to put pressure on a joint, on a nerve, or something along those lines. And then when you change out of that position, then that goes away. As opposed to a purely neuropathic pain, which means that whether or not there's direct pressure on that nerve at that time, that nerve continues to send pain signals. And so, obviously the things that I usually ask for patients is, if you're standing and walking, do you get pain? And then when you sit, does it go away? Do you have pain 24 hours a day? So even when you're sleeping or sitting in a chair, do you still continue to have pain? And so, and then some of the other things that are listed that we always kind of go over with every patient on every visit: symptoms occurring with or without triggers. So positions, different times of day, things along those lines. Whether or not there's weakness or numbness associated with it, pins and needle sensations versus purely of, a stabbing or an aching sensation. Next slide, please. And then obviously we want to understand how much this pain affects your life, right? Because, some patients have pain and, it's there, but it's not necessarily keeping them from doing the things that they need to or want to do on a regular basis. And for some patients, the pain becomes so much that they're not able to perform their basic activities around the house. They're not able to go to work or be able to do the things that make them happy, whether that's playing with your grandchildren or playing golf or going out for hikes. And so our goal as pain medicine providers is to try to help you to live the life that you want to live, right? And live that best life possible. And thankfully, we have a lot of tools to do it. Next slide, please. And so, as we kind of talked about earlier, there is this kind of cascade of starting from the most conservative and working up. And there's a lot of amazing therapies and a lot of patients get help from each step along the way, right? And so listed here are things: physical therapy, some medications, some steroid injections. All of those can provide great relief for a lot of patients. But for when those treatments don't quite do what we want them to do, or don't last as long, or don't get you as active as you want to be, thankfully now in a 2020 world, we have the technology and the ability to help in many other ways. Next slide. So today specifically, we're going to go a little bit farther into 3 categories. And from my perspective, they all kind of fit somewhere in the invasivity range between steroid injections and surgery. And they can be very, very amazing tools and help people to be able to regain function and to be able to do more things and enjoy life better. And so those three procedures that we're going to specifically talk about today are radiofrequency ablation, indirect spinal decompression, and spinal cord stimulation. And these are three things that we've utilized extensively at our practice and have had a number of patients that have done extremely well and been able to get back to many, many different activities in life. Next slide, please. And so we're going to start talking about radiofrequency ablation. And so it's also known as RFA. In the past, maybe some of you have heard radiofrequency lesioning was a terminology that was used before. But really what this means is that we're going to apply heat and radiofrequency waves to a small area to be able to take away nerves that sense pain from joints, right? And so it's most commonly seen as we talk about the spine for those facet joints in the back of the spine. So achy pain that tends to, a lot of patients will say it hurts worse first thing in the morning. It hurts, when I'm first getting out of a chair. Sometimes it gets a little bit better once you get moving around, but then, it starts to really bug you again the more that you do, right? So that's that really kind of constant achy, throbby arthritis type pain. And there are these small nerves that sense the pain from those joints. Along the spine, those nerves are called medial branches. And we have nerves that go to different joints to be able to sense the pain from those joints. So it's neck pain, back pain, buttock pain, knee pain are things that are commonly used or treated with radiofrequency ablation. And the great thing about it is, first we do a diagnostic procedure to be able to say, okay, if we put a small amount of lidocaine next to those nerves that sense the pain from those joints, can we block that pain for a period of time, right? We know that numbing agents work somewhere between 4 hours up to 12 hours for the ones that we commonly use. And if we can block your normal pain for a period of time by doing these simple outpatient procedures, we know that, okay, we can likely target that nerve with radiofrequency ablation and provide you a very significant amount of relief from your normal typical pain. And so, that all of these procedures are procedures that are very minimally invasive. They're done in the outpatient setting. We actually do most of these procedures in our office under local anesthetic. Patients tolerate them very well. And so I think that this is something that a lot of patients have never heard of when they come see us. And then we're able to provide this for them, and patients get back to, hiking, get back to being able to go golfing. Because it is one of the best ways of being able to help and target that arthritis pain. One of the challenges I think that people sometimes ask is, well, you do this, you're targeting the nerves, do nerves grow back? The short answer is yes, nerves grow back. They grow back at a different rate for different patients. But on average, here in America, the large pooled data that we have shows that radiofrequency ablation usually lasts somewhere between 9 and 14 months. And so it's a procedure that, is quick, is outpatient, is extremely minimally invasive. Like I said, for most of our patients is done here in the office, and then can provide a very long-lasting relief for a lot of patients. Next slide, please. And so the next thing that we're going to talk about is what's called the Vertiflex procedure, which is an indirect decompression system for the spine. And so really, to be able to talk about this procedure well, we have to talk about spinal stenosis. And so next slide. Spinal stenosis is the narrowing of the nerve holes within the spine. And specifically, the spinal stenosis that we're thinking about is what we use in a big fancy terminology of neurogenic claudication, which really means just nerves being pinched. And so for a lot of patients, when we stand up, the spine changes its anatomy a little bit, and it pinches off some of the nerve holes within the spine. And so within a short period of time after standing, patients start to develop pain in their back, pain in their legs, sometimes weakness in their legs. But then patients find that the moment that they sit down, the moment that they bend forward a little bit, that the pain improves. And so commonly you'll hear that patients will get to a grocery store and find a cart, and as long as they can lean forward just a little bit on that cart, it takes a lot of the pressure off. The back doesn't really hurt them that much, the legs don't hurt them that much, and they're able to ambulate around a grocery store with very minimal difficulty. But the second they get rid of that grocery cart and they have to stand more upright and support themselves, that back pain and the leg pain starts to happen again. Next slide. And so, spinal stenosis itself tends to happen in a very gradual process. It's not usually something that, happens overnight or with a specific, with any specific movement. These tend to be kind of slower processes that happen as, those discs tend to wear away, as the arthritis in the back starts to develop, and then those little nerve holes start to get smaller and smaller. And so as those nerve holes get smaller, there's less room for the nerves to be able to get out. And so eventually, as those nerve holes are smaller, they become pinched and they start sending painful signals and make it harder to be able to do the activities that you want to do. And this can happen both in the middle of the spine, what we call the central canal, or towards the side, which we like to call the neuroforamen or nerve hole. And so, and these tend to present slightly differently for patients. But the consistent thing that we see is that when patients are sitting, they tend not to have pain. Then the moment patients stand, it starts to build up. And then as they're moving and walking around, it starts to go in the back and then down the leg. And this, pretty quickly after patients sit back down, that pain improves. And so that's neurogenic claudication, and ends up being something that really responds well to what we call this Vertiflex procedure. Next slide, please. And so the Vertiflex procedure itself is a minimally invasive outpatient procedure, and it uses a small implant, which you can see to the right of the screen with those purple wings. And so what it does is it's actually external to the spinal canal. So the place where normally if we were doing things like epidural steroid injections, which can also help to treat spinal stenosis, this stays outside of that area. And so as we're placing that implant in place, what it does is it actually prevents those bones from collapsing down on each other. And so as you stand up, it maintains the space for those nerves. And so what you see the studies that are quoted there, you have the patients that are now able to stand up and walk around and not get that pain in their back, not get the pain going down their legs. We have a number of patients that used to be able to stand and ambulate for 2 to 5 minutes, and now can walk a golf course and be able to do the normal activities in life. And this is not just patients that we've seen in our clinics, but also obviously patients in larger scale studies, right? The studies have shown with thousands of these procedures done that there is a very high satisfaction rate. There's a very significant drop in medication usage across the board, including opiate usage, which is very important during this opioid epidemic. But all medication usage tends to decrease once we're able to create more space for those nerves. And generally speaking, patients are, like I said, the things that we care most about are able to improve their function and able to improve their quality of life by being able to do more things, being able to be out of the chair more. And so, there was an actual study that was done looking at the impact of different disease processes on function and quality of life. And spinal stenosis has been shown to be one of those things that just changes people's life significantly. And so you have patients that at one time really enjoyed going out for walks, and maybe it's to the golf course or walking in their neighborhood or by a lake. But over time, as the stenosis has become more and more troublesome for them, they found that they find themselves sitting more. They stay home. They tend to just do things where they know there's going to be chairs. And so the activities that they used to do that they found enjoyable and brought a significant amount of happiness to their lives, they've kind of cut out. And a lot of people don't necessarily realize how much this has changed their life until they really start thinking about it. And so spinal stenosis is one of those disease processes because it does not always cause pain, right? It is, like we talked about earlier, it's a mechanical process. If you're standing, you're putting pressure on those nerves. Standing or walking, you're putting pressure on those nerves. But if you're sitting, tend not to have pain. And so patients tend to sit more and sit more and sit more. And over time, you cut out more and more of those activities that bring life. And so, when I see, like is quoted on this slide, an 81% improvement in physical function and 75% reduction in symptoms, those are very significant things, because that means patients that used to love to get out and do activities and be social and be able to enjoy other things that are non-sitting activities are now being able to do those again. Next slide, please. And so this next slide shows a little bit about how this is done, which is kind of a feat of modern engineering. We take this small, tiny little device, place it in between the bones in your back. Those are called spinous processes. And then once it's in between those bones in the correct manner, then we turn a little knob. And as you can see from those bottom 3 photos, it comes in and the purple arms are straightforward. And then as we turn a knob, you're able to have those link into those spinous processes, or the bones back there. And it, just like I said, it props those open. And so you have this very minimally invasive procedure that is able to accomplish what used to require a large surgical procedure to be able to do, in terms of taking pressure off of nerves and being able to alleviate the symptoms of spinal stenosis. Next slide. And so now we're going to move on to spinal cord stimulation. Sometimes you'll hear this referred to as neuromodulation, which is just a big fancy term for saying we're sending signals to nerves to change the way that they work. And so this has been another one of the most amazing technological areas of modern pain medicine. And specifically over the past 10 years, during my career, I've seen exponential improvements in the way that we're able to deliver this technology for patients, and the things that we're able to do for patients. Next slide. And so spinal cord stimulation is a treatment for neuropathic pain, right? It is that pain that is there 24 hours a day, that, no matter what position you're in, you just can't get away from this pain, and it treats pain of the back, pain of the limbs, and specifically when we've looked into the large scale clinical trials, and in terms of who really improves with this, we found this changing over time. Initially, we used to treat patients mainly that had failed back surgery, or patients that had complex regional pain syndrome. And we found that patients with chronic neuropathic pain that has been being treated and not able to get the relief that they want to for a significant period of time, that spinal cord stimulation can be a very good option for these patients, right? So like I said, we're talking specifically to patients' pain that is of neuropathic in origin, and tends to be that pain that is there 24 hours a day, and can affect the back, can affect the limbs, but and have gone through all of the normal, less invasive options and without lasting relief. Spinal cord stimulation may be the answer. Next slide. The amazing thing about spinal cord stimulation is, though I specifically talk about the last decade in terms of the massive and significant improvements of the technology, it's been around for a long time. And so it is not something that has just been discovered and we're trying to figure out if this works for a patient. We've been treating patients with this technology for well over 40 years. And so, there's a very significant track record of how spinal cord stimulation and neuromodulation have been able to help patients affected by neuropathic pain. And then, one of the things that I like to talk to patients about with this is it's one of the few procedures in medicine for the spine that is reversible, and you actually get to take it for a test drive. Right, it's where we actually place these leads in place. We leave the battery external for a period of time, generally about a week, and we allow the device to be able to work and find out how it works for you. Right, it's easy for me to say, I've used this device a couple hundred times in the past year. I know exactly what it's going to do, but it's a whole other thing for a patient to be able to experience what this device can do for their specific pain. And so you have the ability to test drive it. And then once it's implanted, if for whatever reason you aren't happy with it, or you have to have something else done, it is a reversible procedure. And so those things make it a very, I think, great option to consider for many, many patients. And then kind of one of the things to point out also, because this is another question that we get regularly, is this covered by insurances, specifically Medicare? Yes, it's covered. It's something that, Medicare actually, I think, really appreciates for patients, because it is so successful in helping patients to improve their quality of life. It's so successful in helping patients to be able to stay off of medications, or get off of medications if they're on them, and just generally improves overall outcomes for so many of our patients. Next slide. And so, really with spinal cord stimulation, what we're doing is we're using electrical impulses to send a signal to the spinal cord. And we know that by doing so, we can change the signaling patterns. And obviously it's a very complex process, but the nuts and bolts of it are, you have pain that comes from your back or from your legs, and we place the leads between your back and your legs and your brain, which is going to process all of that information. And then we send signals to the spinal cord in between those levels. And as we do that, we're able to take those painful signals that are coming from your back and from your legs and turn them into less painful signals, and pretty significantly less painful signals by the time they get to your brain, so that your brain just perceives less pain throughout all activities. Next slide. And so as we go through it, like I said, we'll usually do that trial period first, where the leads are in, the battery is external, and you're going to try it out for about a week. And these are the things that we always look for when we talk to patients. How much has your pain improved? How much has your activity level improved? One of the things that I ask a lot of patients is about sleep. Sleep is one of the most common things that we see improve in patients, because obviously if you're dealing with neuropathic pain tends to affect sleep much more than other types of pain. And so, that pain that's keeping you up at nighttime is usually neuropathic pain. And so we see significant sleep improvements for patients. And then for a lot of our patients, we see that we're able to decrease the amount of medication that they require. And all of these changes, independently, I think are amazing changes to make for patients living with chronic pain. But when we add up that we're able to do all of these things with a treatment modality, it's been something that we've been very happy and excited to offer for our patients for a long time. Next slide. And so one of the other things that I really love about spinal cord stimulation is that we can really mold it directly to each patient, right? Obviously there are a number of clinical trials and scientific studies, and for us to understand, what we believe is going to work for the vast majority of patients, and it always gives us a starting point. But these devices are able to be personalized specifically for each patient. So every patient's pain pattern can be treated as an individual. And, and the technology to do that, where, you can have different programs or different settings for different times of day. And so you have the ability to treat everybody with individualized medicine, right? And I think a lot of people hear this idea of individualized medicine, and it has been a buzzword. But spinal cord stimulation, especially within pain medicine, is one of the areas where we truly have that hands-on approach and that ability to fine-tune every little detail for our patients. Next slide. And so, as we've stated already, spinal cord stimulation is proven with, over 40 years of history helping patients out and clinically effective, right? We have this data that has come out over time that shows that it's not just something that helps people, for the week of the trial or for, a short time, like usually the steroid injections, where, if you look at clinical trials, they last for a couple of months for the average patient. You have spinal cord stimulation that shows 2 years of relief of patients coming from, an average pain score in the 8 range, down to below 3 from clinical trials. And so, that's a very significant pain improvement, and that's a very long lasting pain improvement, right? I mean, we're talking 2 years later that patients are doing this well, and so it is something that has has been around, will continue to be around, but has evolved so much technologically that we can help so many patients with this. And so, personally speaking, I know I don't want to show favoritism to one area of this talk as opposed to others, but this is really my passion within pain medicine, is more utilizing these technologies and all of these advancements to be able to help patients to enjoy life more and to be able to do more activities, more of their normal activities, more of the things that they have forgotten that they loved doing because they've had so many, so much pain that's affected them for years. And so that is the gist of our talk today, kind of running through all of those treatment options. Next slide. If anybody does want to learn more, our practice has a podcast available on all podcast apps, from the Apple App Store, Spotify, or Google. It's called the Spinal Nerve Podcast. We've covered spinal cord stimulation and neuromodulation many times, as well as many other topics within pain medicine. We're on all social media outlets. We just started a YouTube channel to try to be able to educate people more. Our goal as a practice is to be able to educate the community, educate the providers in our community, so that everybody can be able to live their best lives. And next slide. I'm done. Thank you.
Thank you, Dr. Joves. Now we will open up for our Q&A session. If you hadn't had a chance already to type in your questions, please do so now in the chat feature, or you can text my number, which is there on the screen. I know we had a few questions come in already, Dr. Joves.
Yeah, let me see if I can pull them up. There we go. So there is, sorry.
No, go ahead. I was just going to read the question for you.
Oh, got it. I'll read it. I found them. So there was one question that was asking about the usual lasting effects for the Vertiflex procedure. So there's clinical trial data that has come out and has looked at the durability of this response from patients, and we have great data at the 2-year mark, and I believe there has been, maybe don't quote me on this, whether it's been published or whether it was made available to some pain providers in early process, but up to 5 years for the device. And so, because it is, an implant that is going in and it affixes itself to the bone and creates that space there, it has a significant amount of durability in terms of being able to continue to provide long-lasting relief for patients suffering from spinal stenosis with neurogenic claudication. I hope that answers your question. If not, please feel free to respond again. And then the second question that I see here is, can this therapy work for more than one pain area? I'm not sure what that question was in response to. Kelsey, do you have any idea?
Yeah, I think it came in during the spinal cord stimulation talk, so it's
okay,
related to that. Yeah.
Got it. Yeah, so spinal cord stimulation tends to be very beneficial for patients dealing with back and leg symptoms. And so, there are clinical trials that have been done showing effect for patients with neck and arm symptoms as well. But, so depending on what you're meaning by more than one pain area, but if it's chronic neuropathic pain affecting the back, the trunk, or the limbs, spinal cord stimulation has been shown to be very effective for many patients.
Thank you, Dr. Joves. And I do have a Vertiflex question through text message. This patient has had epidurals for spinal stenosis, and they're wondering if they would still be a candidate.
Yes, absolutely. So, as we kind of walked through that initial kind of process of going from less invasive to more invasive, epidural steroid injections tend to, be one of the first tools reached for when we're talking about lumbar spinal stenosis with neurogenic claudication. And so most patients that proceed to the Vertiflex procedure have had epidurals in the past. And so they would absolutely not preclude you from being a candidate for this procedure. It would actually be helpful for your pain provider to know that you've had those done, and that especially if they were helpful for a period of time. I think that gives a lot of great information as to what we can expect from the Vertiflex procedure.
Great, thank you, Dr. Joves. And another question came in as well. It's Vertiflex too. How many Vertiflex implants can be put in? I have been told I have multiple levels of stenosis.
Correct. Yeah. So generally, even with patients with multiple levels of stenosis, what we normally see is that there are usually 1 to 2 levels that are the most significant and the ones that are generally causing the most difficulty for patients. And so, when we first identify what's happening for you, what's going on, and what's the most significant portion of your pain generators, our goal is to identify those specific levels that are the most significant as far as creating that pain for you. And then usually we would provide Vertiflex if that was a good option for you at 1 or 2 levels.
Okay, great. Thank you, Dr. Joves. So while we wait for a few more questions to come in, we do have a quick poll that we wanted to share. So you'll see a few questions pop up on your screen. We're always trying to improve these events, so we would really appreciate any feedback that you all have. Here it is. You should probably see this on your screen. And in the meantime, we'll just wait for some more questions to come in. All right. Let's see here. And Dr. Joves, I just got a text message, and this patient is asking about spinal cord stimulation. What is the recovery like for a trial versus an implant?
Sure. So for most patients that have undergone a trial of spinal cord stimulation, it's actually quite similar to going under or having an epidural done. The leads are placed into the epidural space, and there's not all that much more soreness than from a typical epidural injection that patients have. For the implant, there is a little bit more postoperative soreness, because it does require 2 small incisions to be made to be able to implant the battery and secure the leads inside your body. But generally what I've seen is that patients have some soreness for a few days, maybe up to a week, and by that week point, most patients are healing up and doing quite well. We do ask you to be a little bit more cautious with your activities for about 6 weeks after implant, just so that everything can continue to heal in place. But generally, people get back to most of their normal activities by about a week.
All right, great. Thank you so much, Dr. Joves. Okay, let's see if we have any more last questions before we go ahead and close. Let's see. So this patient is asking about your consultation cost and major insurance companies that you do take.
I don't know our consultation costs, but we are on in network with all of the PPOs, all of the HMOs here in Sacramento, which are Sutter and Hill mostly, with Medicare. We do not accept any of the Medi-Cal programs at our clinic, but yeah, we are on most insurers locally.
Perfect, thank you.
And all of the work comp carriers. Sorry, I'll add that in too.
Thanks so much. Let's see. I don't know if there's anything coming in at this time, but if we didn't get to your questions, please feel free to write them down. It looks like we have another one. Or they're just saying thank you. So if we didn't get to your questions, please write them down, because one of the reps will be calling you within the next few days, so they can go ahead and answer those questions for you if we didn't get to them. as well as you can set up an appointment with Dr. Joves as well to discuss further. All right, so that concludes our presentation for the afternoon. A special thank you to Dr. Joves for being with us today, and thank you to all of you for making the time to attend. If you are interested in discussing any of these therapies, please call the office and schedule your in-person or telemedicine consult today. Thank you all and have a great afternoon.